Hi, everyone. Thanks so much for joining us tonight. We are going to get started with our discussion very soon. We're just having a few technical difficulties, so thanks so much for your patience. I'll be with you very shortly. Well, hi, everyone. It's so great to be here with you tonight. Thanks for your patience as we work out a few technical difficulties. I'm sure everyone's used to experiencing those, especially now more than ever. And I hope you're doing well this evening and just so happy that you have chosen to join us tonight. My name is Megan Klink and I'm the CEO for Susan G. Komen Orange County. And at Komen Orange County, we are incredibly proud to strive to empower breast cancer patients and caregivers with personalized information and resources, improve access to high quality health support, advocate for strong public policy, and fund innovative disease research. We know that breast cancer is not canceled, and we so appreciate you joining us in this fight. And for many people at some point in their lives, they think about having children. And while that's certainly not a path that everyone walks down, many people want to have that option. And some treatments for breast cancer can cause temporary infertility or make it harder for you to get pregnant after your course of treatment has ended. Other treatments cause permanent and irreversible menopause, which means you are permanently infertile. Today, we are going to hear from experts, as well as a powerful testimonial of how a young couple filmed their journey about building a family after a diagnosis. I'm thrilled to be joined here tonight by breast oncologist Dr. Rita Mehta and Dr. Jill Sang, who focuses on gynecologic oncology, both from UCI's Chow Family Comprehensive Cancer Center, one of Komen's proud healthcare partners. Also joining us tonight is NBC thriver and documentarian Trisha Russo, who has been living with breast cancer that metastasized to her brain since 2013. Trish will be joining us and sharing her experience with fertility and family planning options. And I hope that before tonight, you all had the opportunity to watch the incredibly moving documentary Love Always Mom, which is Russo's award-winning film. And she'll be able to address any of your questions about the film tonight as well. And just truly, Komen Orange County is incredibly proud to partner with Chow Comprehensive Cancer Center and the Cyan Gray Hope Foundation, which was founded by Trish, to bring invaluable breast health educational opportunities and panels such as this one we're having tonight to all of you and to the community at large. And before we get into the discussion and bring our panelists in, I do want to remind everybody to please put your comments in the chat because we will have a Q&A after the formal questions, and we want to get to as many of those as we possibly can. And so with that, let's get started. I am so happy to welcome Trish, who is an incredible individual who truly, her strength and perseverance serves as an inspiration to us all. Thank you so much for joining us here tonight, Trish.
Thank you so much for having me. It's an absolute honor to be here and to be on this panel. I know that when we first talked about doing a screening of Love Always Mom, it was pre-pandemic and it was in person. So I really applaud your team for pivoting and continuing to create these valuable resources for the community at large. If I learned anything from my thrivership and from building family, it's that life is precious and it can be hard to stay alive. It can be hard to create life. So I am thankful to be here on so many levels with you all tonight.
Oh my goodness. Well, we are so grateful to you. And, we just want to start it off. We'd love to understand what made you decide that through everything that you were going through, that you were going to pick up a camera and film your journey about building a family after diagnosis.
Yes. So where to begin? I mean, the quick of it is I had a background in film. I went to graduate school at USC, and in my 20s, I was really building my career. I tabled building a family in my 20s because I was building a career. And that career was in entertainment. I worked for companies like Miramax Films and Walt Disney Motion Pictures. And then I was diagnosed with cancer. And around the time of my metastatic diagnosis is when I actually decided to jump off that ladder and focus on my health and focus on trying to build a family, because that's what my husband and I really wanted to do. And I have to be honest that leaving my career and having the cancer diagnosis really shook my identity to its core. And ultimately, eventually, I found a counselor who focused in young adult cancer patients at Sloan Kettering. And she was pivotal in helping me identify that I had a huge struggle about building a family and did not really even know how to do it after my metastatic diagnosis. When I was in the room with the nurse practitioner that she introduced me to, who walked me through all the options, my filmmaker brain was literally looked into the corner of the room where there was no camera at the time and was like, where's the camera in this room? Because I feel like I should be on camera right now. Because I know that I'm not the only person sitting in this dark tunnel at this time, not knowing how to start this journey. And this nurse was really shining a light into that dark place. And, after I left that room, I had hope again. And I had somewhat of a path to at least get started. And then I started looking for more resources, and I was really having trouble finding them. So I'm like, you know what? We're in this moment. We know how to use a camera. We know how to make a movie. Let's get started. Let's do this. Let's be the resource. So that is how I picked up a camera and had that aha moment. It became an art therapy in a sense for me during the whole process of filming, because it took years to film. And ultimately, in hindsight, it really helped me reconcile my identity as well, my pre-cancer life with my life post-cancer. So.
Well, remarkable. And just to be able to use your film now as a resource to so many, it's really powerful. And when did you know that family building was going to be an issue for you?
Well, I was diagnosed initially stage 2B with breast cancer when I was 30. And like I said, I focused my 20s on building my career. My husband and I always wanted to have a family. But it wasn't going to be until I got to a certain place in my career that we both felt comfortable. But then cancer diagnosis happened at 30. I had to do chemo, mastectomy, and radiation. And before I started chemo, to be honest, you're in such a fog when you get diagnosed that I can't remember if my oncologist told me that fertility could be an issue, with chemo, or if it was my mother Googling, because it might have as well been that. But I did get the opportunity to sit down with a fertility specialist right before I started chemo. And they counseled that they felt like my cancer was too aggressive to wait and that I should start chemo sooner than later. So I knew that it could be an issue starting then. And then once they found out I was estrogen positive and had to be on tamoxifen, you can't get pregnant on tamoxifen and then on Lupron shots, they were, I was thrown into menopause in my 30s. So I knew that it was going to be an issue then. So we always had an ever evolving plan of how we could potentially have a family. When I was still early stage, it was potentially getting off of tamoxifen early with the counsel of my medical team to see if we could try to build a family. I had met other women who had done that. But then I became metastatic in February of 2013 when they discovered the tumor in my brain, and that really tabled my opportunity to get pregnant myself, and started a whole nother journey.
Absolutely. Well, I think that, thank you so much for sharing that. And this is a good time to bring in our doctors to add to this discussion. And I'm so proud to welcome Dr. Mehta and Dr. Sang from UCI's Chow Cancer Center to the panel. And just want to share a little bit about both of them. And so as a medical oncologist specializing in breast cancer, Dr. Mehta designed individualized treatment plans for each patient with a focus on their physical and emotional well-being. She is the principal investigator on several active interventional clinical trials and has led a North American trial in hormone receptor positive breast cancer, where she and her colleagues demonstrated an improvement in overall survival by combining 2 hormonal blocking agents in metastatic breast cancer. And joining her is Dr. Sang, a gynecologic oncologist with specific research interest in the perioperative care of women undergoing gynecologic surgery. She is a principal investigator on several active interventional clinical trials for improving the care of ovarian cancer and just came from surgery to be with us tonight. And we are so grateful. And together we are going to explore how breast cancer and subsequent cancer treatments impact fertility, and with Trisha's own experience considering family building after a stage 4 cancer diagnosis. And so please join me in welcoming Drs. Mehta and Sang along with Trish as we get into this conversation. Thank you all for being here. And so as today we get this rare opportunity to talk to 2 oncologists who have very different areas of specialty but both work with young premenopausal women dealing with a cancer diagnosis, with Dr. Mehta focusing on breast cancer and Dr. Sang on gynecological cancers. And so this question is for both of our doctors. What are your thoughts on discussing potential fertility issues with a newly diagnosed patient? And how may that conversation differ based on age or stage? Oh, Dr. Mehta, I think you're still on mute.
Yeah, basically, whenever the patient first comes to you, they are in a shock, and the first thing that they're worried about is breast cancer. And then suddenly, when we start talking about chemotherapy, hormone therapy, depending on the type of cancer, then suddenly they realize younger the patient and they have not yet started their family. The first thing that comes to their mind is, oh my God, am I going to have a baby? And touch wood, over the years, so many treatment options and so many chemotherapies that can preserve fertility, or ovarian function suppression that can preserve fertility in patients who have hormone receptor negative disease, or even in same thing can be applied for patients with hormone receptor positive, with some caveat that those patients may be slightly at high risk of breast cancer relapse, given that we are manipulating hormones. So that's a discussion that we have with patients. And there are some patients who choose to put away some eggs or put away some embryos before starting their treatment. Or there are some patients who go for ovarian function suppression while they're starting their chemotherapy. So those are different options that the patients nowadays have. Even if some of my patients haven't even done anything, they still get pregnant after we have treated them. Younger they are, the more the chance that they will get pregnant. And older they are, lesser the chance that they'll get pregnant on their own. So then we bring in different options for those patients. Jill.
Thank you.
And from a GYN oncology perspective, so of course, when we see patients, fertility is always part of the conversation for women who haven't completed childbearing. given that we deal with uterine and cervix and ovarian cancer, so a little bit more of a direct impact. And, you know, fertility preservation in our cancers is really focused on women who are younger than 40 years old, but sometimes a little bit older than that as well. And the conversations are absolutely based on patient stage. Sometimes for our cancers, and probably similar to breast cancer, early stage disease tends to be more amenable to fertility preserving treatment. Sometimes we can do fertility preserving surgeries for ovary cancer or cervix cancer, or even medical management for uterine cancer as well. But for later stages, sometimes we do have to go the route of oocyte harvest or other reproductive assisted technologies to make sure patients are safe and we value their goals as well.
Thank you. And Trish, can you share what your experience was like after being diagnosed with metastatic breast cancer?
Absolutely.
And considering family building? Yeah, sorry.
No. I think, you know, first for me and my husband, it was a bit of a mental hurdle, right? To come to terms with the statistics, like what the prognosis means. You know, for anyone who doesn't know, you know, the current median life span of a woman when she's diagnosed with metastatic breast cancer is about 3 years. That's still the case. So knowing that statistic, and then my husband and I having to reconcile still wanting to build a family, knowing full well that that's the statistics. And also hopeful that research will focus on metastatic breast cancer and give us longer lives. But you're making your decision right now. So first, my husband and I had to kind of grapple with that, make that decision together. No, he full well I had to make sure that he was very aware of that and accepting of that, because I think there's a bit of denial in the family of what it all means. So I'll never forget when we signed our contract, or we're about to sign our contract with our surrogate. I walked into his office and was just like, I want you to know these are the statistics. I know we've talked about this a million times, but before we sign this, I want to make sure you know the implications of that. And I'll never forget his answer was, I think that you are going to be here. But if you're not, there is nothing I'd rather do than raise our child in your honor. And I think that was, for me, you need to have, it's not just the woman. The woman should make the decision or be part of the decision, but in this case, it is a couple in many cases. I also needed my family support, and then also I wanted the support of our medical team. And I was very thankful that our oncologists, I had two, one in Los Angeles and one in New York, because I was bi-coastal at a time, that they were both supportive of us trying to build a family. And I only know how lucky I am actually in retrospect, because I've met so many patients now who are stage 4 who have not had the same experience with their medical teams being supportive of the opportunity to build a family. And I think that that's also become critical in sharing our film and talking to medical professionals, that they can at least be sensitive to knowing that this is still something that somebody who's stage 4 may want, and how to have that conversation with them. The only direct experience I had was when I applied for a clinical trial and talking to that researcher, and when I asked what the long-term side effects were potentially of the trial drug, because I wanted to make sure that I could potentially still have a child at that point. It was very soon after my metastatic diagnosis. She said, I don't understand why you're even concerned about building a family right now. You should be concerned about staying alive. And I know that that's true, but I was concerned about both, because that was part of my quality of life, was being able to be a mother. And then when I cried in front of her, she did say, I don't know why you're crying. It's not like I'm telling you that you have to have your uterus removed. And I didn't really know how to handle the conversation at that point. I very much just shut down. And honestly, it was that one interaction for me was negative in any way. But I do use that as a touch point of, it's nice to have, I'm very thankful to have these dialogues with oncologists, so that, you know, there is this conversation about sensitivity and about quality of life and about personal choice.
Thank you. Thank you so much. And that does kind of lead for a question for Dr. Sang about does the oncologist and the fertility specialist work together as a team during the fertility preservation or when a patient does decide to utilize frozen eggs or embryos?
So we absolutely work very closely with the reproductive endocrinologist and the fertility specialist. I actually have several of them on speed dial for me. But yeah, it's so important to partner with them because they're an integral part of the team in taking care of our patients and getting them where they want to be in life. For us, again, that could be timing site retrieval, getting stimulation going as fast as possible. It could be planning, planning IVF after medical management of endometrial cancer or retrieving eggs after, systemic therapy before for breast cancer. So a lot of things that we need the expertise of the reproductive endocrinologist to assist us with and work with us.
Thank you.
I agree with Jill that we ask patients to partner with fertility specialists before starting treatment and once they are done with treatment, even afterwards, because that's an ongoing thing for patients. And when we say that it's time for you to, at least we ask them to at least have 2 years of treatment in case of triple negative breast cancer, or for that matter, HER2 positive breast cancer. And even for hormone receptor positive breast cancer, minimum of 2 years of treatment they should have before they plan to have a baby. Some patients have gone on to, they have had frozen eggs and frozen embryos, but they had, once they stopped their treatment, they got pregnant on their own. So every patient is different, every patient's fertility is different, and obviously younger the patient, more the chance that the patient would still be fertile afterwards.
Thank you. And I mean, this could be for either one of you. How would you counsel a patient who wants to preserve, but they are BRCA or have other genetic indicators to take into account? And can embryo testing identify BRCA or any other genetic mutations that could be passed on to a child?
Yeah, very good question. Some patients with BRCA mutation, they nowadays can undergo a pre-implantation genetics because patients tell me that they don't want to pass that gene to their daughters or their sons for that matter. And so now it's possible to do a pre-implantation genetics and then only implant the embryos which do not have those mutations. And there have been successful pregnancies with pre-implantation genetics. And I think the first case was only, 5-6 years ago that was published in New England Journal of Medicine. Since then, it's quite commonly done.
And many of my BRCA patients who are young, especially now that we're identifying more family lineages with BRCA, and so more young women are finding out through family testing that they are BRCA positive and being proactive about their care and their surveillance screening for ovary and breast cancer. They are seeking oncologist care earlier. And so many of these patients actually do want to work with a fertility specialist. I encourage them actually to harvest eggs early if that's what they're interested in. And so that if we are faced with a cancer diagnosis somewhere along the way earlier than we expect, that they can have, children naturally or ready for that, that at least there's, there's a backup plan for them in place.
Great, thank you. And Trish, when after your stage 4 diagnosis and your estrogen receptor positive status, you were actually advised to not carry a pregnancy. Can you share just how you were able to cope with that?
Yeah, it was really after my metastatic diagnosis that I was counseled not to carry the pregnancy because of the ability to treat me depending on if something were to occur. was a major consideration, as well as for egg retrieval was me having to get off medications early to do that. So that's why I was counseled not to. Yeah, I mean, it was a lot of tears. It was a lot of crying. I was trying to be, meanwhile, I'm the oldest of 5. Meanwhile, all my brothers and sisters were starting to have their children. So I became an aunt many times over, which is a beautiful thing, but also very challenging to watch other people, have children and build families so easily when you're struggling. But I tried to channel it into being the best aunt I could possibly be. And then finally, decided that it meant more to me to become a mom than how I became a mom. Mm-hmm. So that helped me let go of many factors. It helped me let go of the loss of being able to carry myself, or let go of being genetically related to my child, and when we had to utilize an egg donor. So just focusing on the end goal of becoming a mom liberated me to make other decisions and choices to make sure that I could become that. We did explore adoption and fostering to adopt. Adoption, honestly, we did not go far down the road. We were counseled that it could be quite difficult as a stage 4. So not to say not to do it, not to try, but it can be hard knowing the prognosis to go that alley. Foster adopt can be easier in that respect. So, but my husband was like, we've been through so much emotionally. You want to bring children into the home and then have them taken out of the home, and then have somebody, you're going to be gut wrenched every time. And so that was a hard decision to table that conversation as well. But I do believe that if this didn't work out for us for egg donation and surrogacy, I would have found another way. So
Thank you. Thank you so much.
I think it's beautiful however you become pregnant and have babies, right?
Absolutely.
Have a baby, right? That bonding is so critical. And I think that loving environment that you fostered is also one of the reasons you're surviving this cancer.
Yeah, I mean, it's hard to say, but the positive mindset, having something to really live for. I mean, and it's hard to say these things because I've met many people who have those things and don't, unfortunately, survive. So it's hard to, but he does light up my life every day. On the days that might have been, more challenging to get out of bed when I wasn't feeling great, I have to get out of bed for somebody else. Like the mom juice turns on and you just go. So I do think I agree. It does not matter how you become a parent. If you want it, then you'll find a way, and it is a beautiful thing.
Absolutely. Well, then, so I'm just going to just move into, because I know that some of you who are tuning in tonight, you have seen Love Always Mom. And so we'd love, Trish, for you to hear just what's the reception been like? How is your health now? And spoiler alert for anyone, I think you may have picked up on it, but how is your son?
Can we? He's probably eating some pizza in the other room. He's like, Mom, I'm playing. I don't want to come. The reception to the film has been, honestly, beyond my wildest dreams, because, like I said, when I originally picked up the camera, it was very much like, we have to film this. I did not honestly know what the end of the story was going to be. I pre-visualized it as much as I possibly could, but I honestly didn't know at times whether or not I was going to be telling the story of starting our family, or if I was going to tell the story of me dying from metastatic breast cancer. Because when we picked up the camera, it was only 1 year since my brain surgery, my craniotomy. Thankfully, it has now been, in February, it'll be 8 years since my brain surgery, since my metastatic diagnosis. Again, the 3-year median, that far surpasses that, and who the heck knows why. But to travel to film festivals, to see my son born, which was something I did not know that I was going to see. And then to be able to raise him all these years, and he's turning 4 next month. It's crazy how fast it's gone. And then traveling the film festival circuit and winning awards with the film, which honestly just gave more attention to metastatic breast cancer and infertility issues, which was what we really cared about. And then being able to meet other people after the screenings and learn their stories and what they have been through. It was really inspiring. And I've learned, I knew before, and I've was reinforced that everyone has their own story. And I just urge everyone to share it, because you never know who it's going to help.
Thank you.
I will lastly tell you, though, the extra bonus of making this movie is, since it's now on Amazon Prime Video and every minute streamed is a little drop in the bucket for the Cyan Gray Hope Foundation. And we split money between metastatic breast cancer research and offering a family building grant for a cancer survivor. So this year we are offering our first family building grant, and we chose our lucky couple that is a breast cancer survivor. It can be any kind of cancer, but in this case, she is a breast cancer survivor, and they are about to start their surrogacy journey themselves. Oh. So we are going to hopefully be creating another family.
Amazing. You continue just to bring so much good. So
I'll have to pay it forward.
Yeah, that's incredible. Well, I had moved things around a little bit, so I apologize to our panelists, but I did want to go back to Dr. Singh, because I think this is really important. That what would you consider a successful preservation cycle? And would you ever recommend multiple cycles if the patient did not get enough eggs on the first cycle? Yeah. How long does a patient need to wait between cycles? And how do you balance this with the oncologist and their need to begin treatment?
So I just want to preface this by saying I am not a fertility specialist. However, I do know a little bit about this. So in general, I mean, they've looked back at many, many women and many cycles over the years. And what they know is that the more eggs that are harvested during one cycle, the more likely you are to get pregnant. And there's a lot of factors that maybe go into that. But sort of like the ideal count, or sort of the minimum count that is called a good harvest, is around 15 oocytes. And we think that, or the research shows sort of that past 20 to 30 oocytes in one cycle doesn't give any extra benefit. So somewhere between 50 and 20 or 50 and 30 is appropriate. We consider people who are having a little more difficulty, patients who undergo stimulation but maybe only get a few eggs, like 3 or 4 eggs. In terms of more than one stimulation cycle, I think it's really important to look at the reasons as to why someone may have been a poor responder. If someone's a poor responder potentially because of age or other conditions like endometriosis or damage to the actual ovaries, then they're less likely to respond with another cycle, and it may be more prudent to proceed with cancer treatment at that point. Whereas someone who may have a situation that can be remedied very easily with different hormone levels or adjustments in their stimulation cycle, that potentially could warrant another cycle depending on how aggressive someone's disease is.
Great, thank you. Thanks so much. And before we move into the Q&A portion, we do have a final sort of official question, if you were, for all three of you to respond to. And that is, if you could say one thing to a patient about family building after a cancer diagnosis, what would that message be?
So I think what I tell my patient is our goal is to make sure that mom is healthy, baby is healthy, and it's not mutually exclusive. We have had patients who knew that they got breast cancer and they were being treated for breast cancer and then found out that they had pregnancy, that they were carrying a pregnancy. So even in that situation, we were able to get her through pregnancy and delivery. So these things can occur, and ultimately our goal was to make sure we adjust our treatments so that she can carry the baby to term, or at least till the lung maturity, and then deliver and then give her full throttle treatments. So everything is possible nowadays because we have so many new treatment options and so many ways of treating infertility. And like in your case, Trish, surrogacy was very important for you. So many different ways that not only we are improving breast cancer survival, we are also improving patients' chances of having a baby.
Thank you.
And I would say that, quality of life is very, very important. So it's so important. And as oncologists, we always want to know what is important to a patient in terms of their quality of life. It's quantity and quality both. And especially for women and young women, building a family is often one of the most important aspirations or goals. And so we want to know about that. We want to know where that fits into treatment and how we can facilitate that while still keeping patients as safe as we can.
Thank you.
And I think for me, I mean, anyone who has cancer, no one's planned to have cancer. So to just acknowledge that how you become a parent and all of this is going to likely look different than you ever expected your life to be. But that sometimes plan Z can actually be better than plan A. So to embrace that process, and it's your personal choice. So go for it.
Love that. Plan Z.
Plan Z.
And so from the Q&A, Trish, there is a question for you. And that is, it's framed this way. You had to not only find the right medical teams for your MBC treatment and for fertility, you then had to locate the right egg donor and surrogate. How did you emotionally hold it all together?
Emotionally hold it all together. I don't know if I did emotionally hold it all together, but I think that's okay. At the end of the day, you have to pick yourself back up. In the film, in making the film, I actually call it the picking up the pieces part of the movie, where there's just the lowest, or you're not sure if anything's ever going to happen. But then I do believe in that when you get knocked down, you have to pick yourself back up, whatever that looks like, and keep trying. And keep building. And we were very lucky. Our egg donor and our surrogate, you see it in the film, and it actually did happen as quickly. They were the first people we met. We met one egg donor, loved her, done. We met one surrogate, loved her, we were on board, let's go. So we just got very fortunate in that way. We didn't edit out the film and only show the one person that we ended up going with. I think how we found people that were such an incredible fit for us was being very honest about what we wanted out of the relationship, the journey, the experience, how involved we want to be. We thought about those things in advance so that we were really able to communicate that to build our team. Because if they didn't want the same things, then they were probably not a good match for us, and we should find somebody else. And again, we use an agency to find our egg donor and our surrogate, which I had no idea that agencies even existed to do that at the time. I only found that out by starting to tell people that we had to do this. And literally I was at lunch with somebody, she was a manager in Hollywood, and she was like, wait, you have to do this? Oh, hold on. She speed dialed somebody on her BlackBerry, handed me her phone and told me to step outside. And that woman became my surrogacy agent. Was a surrogacy agent who was also a cancer survivor, actually, and had her family through. There's put it out into the universe if you're comfortable with that, and you just never know where it's going to lead. And some people, it's financial, it's expensive. So, we did consider family members, friends, anybody who could help us at first, because it can be quite prohibitive. So don't forget that there might be people in your life that already can be those people for you, those angels for you.
That's great. Thank you. And this is for all of you. Do any of you have recommendations on support groups that are for fertility and cancer issues? And specifically for our doctors, are any specific resources at the Chow Cancer Center that are available around these issues?
So I usually send my patients to Fertile Hope. And then there are websites that patients can go on to. And these are patients who are survivors, breast cancer survivors, and they can hook up with these survivors and who decided that fertility was an important issue for them. And so they got their treatment, and they are on Fertile Hope websites. So and then there is young adults with breast cancers. And they also have their separate websites, because young adults obviously have very different set of priorities and different challenges when they are getting treatment for breast cancer.
Thank you.
I have several reproductive endocrinology specialists who are sort of in my contact book, but certainly I think a lot of the support systems and referrals are available on the web, and patients often are so much better at seeking out those particular groups and resources, and so often there's intercommunication with different patients. That's really helpful.
Trish, anything to add there? Any way that you would get connected to other patients?
Yeah, I honestly, I kind of inherited adminning a private Facebook group from a woman who unfortunately did pass away from metastatic breast cancer, but had wanted to build a family. Knew that it was far down the pike for her, but was trying to get as much many resources as possible. So she started this group, and after she passed away, I continued to facilitate it. And it is for women with metastatic breast cancer, so kind of niche in terms of the cancer realm. But we do kind of help each other talk about where we deal with the emotions of it all. And if we are on the journey, cheerlead each other along. My foundation, like I said, we hope that the grant that we're offering this year for a cancer survivor to build a family does become an annual thing. So continue spreading Love Always Mom around so that we can continue funding the grants, I guess. And Baby Quest Foundation, who we also partnered with to vet the applications. I do know that they do offer at least one cancer family building grant per cycle. So again, if you're looking for financial resources, obviously not necessarily emotional resources, it was very key for me to find that counselor, Dr. Jennifer Ford at Sloan Kettering. So somebody who understands psychology, particularly of young adults, people who are in this family building age realm, I think is so important to have somebody to talk to. So to seek those psychological services out, if your cancer center has them, or if people have recommendations. I have advised other places, and Komen could do this as well. Like, it'd be great to have more of that as a resource for people to find. I can't tell you how challenging it is, and I hear this from tons of cancer survivors, how hard it is to find a therapist that also understands cancer. It's like not hard to find a therapist, but when you talk about cancer when you're in a young adult, they just, I don't know, there's so much about like suck it up and keep going. Like, they just don't necessarily understand. So it is why we lean on other patients so much for that support, because we feel like they are the only ones who really truly understand what we're going through. But to have therapists who do really understand that and know how to talk about that in a sensitive way, I think is critical.
Absolutely. Thank you so much. And no other films in your future?
Well, we're not doing no other films.
Okay.
Right now, we are actually filming the cancer survivor who's going on the surrogacy journey.
Okay.
We are filming it so we can show another account of what the process can be like, because it probably won't be like ours. Every journey is different. But because of social media these days, and because of the medium of how we all consume content is different, we are going to be doing it more. We're not waiting to save all the footage to cut a film. We will be People who follow at Love Always Mom, the movie on Instagram, will basically see the journey in real time.
Excellent. Excellent. And just one more thing. What is the name of your MBC Facebook group?
It's Stage 4 Surrogacy and Support.
Okay, great. Excellent. Well, oh my goodness, that time just flew by, everyone. And I just want to say a huge thank you to Dr. Mehta, Dr. Zhang, and to Trish. And please, everyone, go check out the Cyan Gray Hope Foundation and the UCI Health Child Family Comprehensive Cancer Center. Just really, it meant so much for you all to share such important information. Oh, I think we might be getting a little surprise here from Trish. So I'm going to keep us all on because it's worth staying. But yeah, just truly grateful for your time that I know you really don't have to give. So it means a lot to everyone.
Oh, he is a little ham. I have to be honest. At this hour, you never know if you're going to get hammy or whiny. So
we're ready.
Hi, look, people want to say hi to you.
We want to say hi.
Hi. Oh my goodness.
Is how old you're going to be? How old are you going to be?
4 years? My
4.
goodness, you're a young man already.
He is.
So
Ready?
nice to meet you.
I need to go.
Okay, go. Have fun.
That's perfect. So do we. So a huge thank you. It's just so much appreciation. So grateful to all of you. Thank you. Thank you.
Thank you for having
Thank
us.
you,
It was
everybody.
nice
Thank you for
meeting
having us.